shared visits when working with a mid-level, and then move into procedure coding and documentation, and then touch briefly on moderate sedation today. So just as a reminder, when working with a mid-level, as an attending, you have to show presence of participation when caring for that patient. It can't simply be seen and agree with above. There has to be some notation that you actually saw the patient face-to-face, and we capture that by either your own history of present illness and a little bit of exam and your medical decision-making, whether you agree with the mid-level or not, and here's why. I stuck in a couple examples of an acceptable addendum, which if you look through it, pulls out notes. There's a little bit of HPI and their own attending's exam that proves to me that you saw the patient, you saw the weights of their eyes, versus one on the bottom which just says pretty much, I personally perform supervision of patient's care and the medical decision-making, but it doesn't prove that you saw the whites of the patient's eyes, not just review the medical record documentation, which you may have seen the patient face-to-face, but again, it has to be documented to support it, because if an auditor came in and pulled that, we can't really prove that you saw the patient. Hopefully that makes sense. I wanted to move into procedure coding and evaluation and management services.
Karen, can I just ask, so the reason you bring that up, are you seeing that more? Or?
We're seeing a shift back to more of the teaching physician brief description on the bottom on our level 4s and 5 inpatients, where we're not able to capture for the attending the level of care it's going to the mid-level. So because we were doing really well and we're starting to see the shift go backwards.
Are you notifying those particular providers?
We're not. If you want us to, we can, because we're working actually about 2 and 3 days out in coding. We can send you through Beth a notice if you'd like. I guess I'd leave it, if you remember that patient well enough. Do you want us to send it back on the...
Yeah, we'll talk about that.
Okay. In the ED, in order to charge an evaluation and management service and a procedure, there has to be a separately identifiable evaluation and management service in order to code for both. So we look for something that's separate and distinct. Specifically, the example I want to use, or I should say that every evaluation and management service has a little mini E&M, every procedure has a little mini E&M built into it. If it gets into the more complex procedures, we can carve out an E&M and a procedure, but for those simple, we always use the simple potato cut. If a patient comes in and they have a cut on their finger, it's fairly straightforward. Yes, you need sutures. We're not going to carve out a separate evaluation and management for that. We're only going to give you the procedure credit. It's just those simple little things that are fairly straightforward, should be quick, easy in and out. Versus those that are more complex, I fell down the stairs, I broke my elbow, I have a head injury. That to me is something that's a separately identifiable service. We're going to possibly charge for treating an elbow fracture or a laceration and an evaluation and management service. It's above and beyond the specific complaint for that procedure. And the biggest thing we changed this year is now that we're going to take credit for fracture treatments in the ED. If it is apparent to us down through the documentation that either you manipulated the dislocation and or fracture, or if it appears to be the definitive treatment for that fracture and you're sending them to the orthopedist 3 to 5 days, follow up in a week, we're actually going to take the fracture treatment code and an evaluation and management service. Whereas before we were only taking the splint charge and an evaluation and management service.
Define what you mean by definitive care.
If it appears that it's non-displaced and they're not going to have surgery or anything other than wear that splint, we're going to take that.
So splinting is acceptable as opposed to casting?
Yes, is that treatment for the definitive. We are taking it with a modifier 54, which I know is my language, not yours. We're taking that to tell the payers that we're not going to do the global period for that fracture, we're only doing the initial treatment. We did have a few exams where the patient came in. One I can think of specifically is they fell, I think skiing, and tore a bunch of ligaments, and the patella was dislocated, and we sent them right to the orthopedist. So in that case, we only took the evaluation and management service and not any kind of fracture treatment or anything with that.
But regardless, it is an important point that Karen's making, because this is not the way we were doing it before, and we are providing the majority of the definitive care in these cases.
This also applies to the dislocations. When we take the fracture treatment code, we cannot also take for the splinting of that. That's incorporated into the fracture treatment. But if we do apply a splint for services that is not restorative, or we're doing it to stabilize a fracture, afford pain relief, but you're not expected to provide any more care for that patient, and it's properly documented that you applied it. If a tech applied it, we're only going to do a tech charge. If you applied it yourself and it's documented, you're going to get credit for that as well. But there are a few cases when the splint is considered off the shelf per Medicare, like your ACE bandages, your Aircast cast shoes, and those listed there. We cannot take separate credit for a splint application on either side, technical or professional. That is all incorporated into the evaluation and management service. We did carve out separate CPT codes assigned for the ones listed up above because those aren't prefabricated off-the-shelf splints, so we are applying splint charges in those cases. I want to talk quickly about moderate sedation and possibly circle back to it. Not a big focus today. The big thing about moderate sedation is it starts with the push of the first drug and ends with the physician face-to-face time. We have to have a clear start and stop time in order to give credit for moderate sedation. We do see some procedures documented with procedure 15 minutes. We are able to pull out sometimes from the patient flow summary a clear start and stop, but there are a lot of cases where we can't find a clear start and stop for moderate sedation, that we're unable to pick it up. But I should also mention there are a few procedures that include moderate sedation where we're not able to carve that out separate because it's incorporated into that treatment. And I can't think of an example right off the top of my head, but some of the hip dislocations might include moderate sedation where we're not able to charge for that separately. But if we can pick it up, we are picking it up. But I'd like to work with Dr. Molinari and Dr. Riccio to help clarify a clear start and stop time to capture that moderate sedation time. That's all I have for today. I don't know if anyone has any questions, clarifications.
Does everybody understand the start and the stop times as well?
I do. I mean, I think it's good faith estimate, but I'm a physician. I'm not, I don't look at my watch on a regular basis. And I'm not going to tell you I did something face-to-face that took 90 minutes when it's actually 10. But on the other hand, I'm a physician. I'm running around from patient to patient, trying to do as much as I can. And just like our documentation, frankly, takes up probably 2/3 the amount of time that we spend in the ED, I can't be spending time trying to figure out, well, you want to provide me with a stopwatch, that's fine, I'll try and do it on a stopwatch, but
I think it's more of a good faith estimate.
We're looking for a good faith estimate. We know you're busy.
And that's fine, you're not going to get specific times to stop.
As long as it's a good
Stop
faith
times.
estimate and it's within the times the patient was here, we're taking it. If we can get, right now I say that because on the infusion side, we have infusions being documented stop times after the patient's been discharged. I can't count that. But if it's a good faith estimate and the times the patient's here, we're giving credit for that.
Can you use the nursing?
Yes, if the nurse has documented a clear start and stop time,
On their procedure sedation, I thought that they actually had a record.
we find it hit and miss. There's some that have it in there, then some that do not. So I'm not sure, I'll have to again go back and work with
That
those.
doesn't address when they've actually left the room.
That's the other piece. If you're taking the nurse's start and stop time, moderate sedation ends with your face-to-face time. So we might be missing a few minutes here and there.
It would be very helpful for us to get the feedback, even if it's
Yes.
several days later, because even if it doesn't affect that particular case, there will always be ones coming up.
I am collecting as we go. I'm working through, going through and auditing 10 notes from every provider this quarter, and I will follow up with you. I'm working through Jamie to set up appointments and try and catch you either before shift or after shift. And I am having the coders with things that are kind of flukes or things that we're not able to capture. I'm throwing them in a folder and pulling them out when I'm going to come meet with you, and we'll walk through that.
So does that make sense too? Because I think that, so Molinari and I did it first last week. So we sat down with Karen, she pulled 10 of our charts. Actually, she pulled more than 10 of our charts. And it was actually very helpful. I've actually never seen how they do what they do. And we went through each one of those charts and we actually picked through what we did wrong. And, what the cool thing that Karen did is she also noted what they can do very helpful for everybody. So, and I think, so everybody knows I did better than Molinarian too.